Give him a hand, please.
All right, I'm going to set my timer here just to make sure, keep us on track. Gene is really slamming his fist down today. I saw we had started and the room was just filling up. But what I'd like to ask everyone before I get started is how many people have looked up research studies on medical cannabis that have been published this year? Okay. And how many people have looked up studies on weaning patients down on medication that was published this year? All right. So if you search cannabis and look at the studies that were published just in 2025, you'll find almost 2,000 studies that mention cannabis. I'm not saying that they're all looking at it for the benefits of it, but just that mention for 2025. If you search marijuana, you will find almost 2,000 studies that have been published just this year. So it's impressive the number of studies that we would have to go through to find what we might need for a particular patient. And as I'm going through the presentation, I want to point out, and I'll point out some things that we should keep in mind, and I'll reference some of the previous talks as well, as how can we increase the safety and the long-term outcomes of the patient as we're giving the cannabis recommendations. So, when we think about our specialties and our duty to the patient to do no harm, we're practicing as pain physicians, we're practicing as mental health specialists, we're practicing as sleep specialists, we're helping patients with stress, and we're adding a new medicine, but there's so much we can do to reduce medications to increase the long-term safety and outcomes of patients here in Florida, Georgia, and the other states where we have visitors from. So these disclosures were covered a little bit earlier. I'm the medical director of Trulieve here in Florida. Also am an interventional pain physician with a background in anesthesiology. So I might be biased in terms of my dosing regimens and recommendations. In anesthesia, we tend to dose to get a certain outcome. So we might have a textbook dose, but if that dose doesn't get the patient unconscious for surgery, we're more liberal to get a specific functional outcome. And it might be a different mode of thinking where we're used to dosing at 5 milligram, at 10 milligram, and specifically sticking to those increments. There's another way to think about dosing. And so, when we think about unit dosing in those units, there's another way to look at it as a functional dosing that we're looking for a specific outcome. And some of those outcomes that we can help patients with is overcoming polypharmacy. So this is an important slide, and I welcome you to take a picture of it to make sure that I'm meeting the objectives and the goals for the presentation today. So we're going to define and explore what is polypharmacy, talk about the consequences, and in some of the presentations later, they'll be talking about economic burden. I'm going to talk about a therapeutic strategy, keeping in mind specifically Florida and Georgia, legal landscapes in mind, and then talk about some of the research studies and suggest some research studies on polypharmacy to review to get more knowledge and more experience with this. So I'm going to try to keep us on track. I'm going to take this now. I'm going to be in charge of this, so I'll let you know when 5 minutes is left. Because this is important information, GP. We need this information. All right, so this is just a search on polypharmacy of studies that have been published this year, over 600 studies that mention polypharmacy. And if you look at since 2020, the studies that have been published, it's almost 7,000 studies that mention polypharmacy. So we have a strong duty to our patients to be updated in the latest and best information, but also, this is not a reasonable amount of studies to go through. We have obligations to the patients. We want to be up on the most up-to-date information. But 7,000 studies on just one topic, that's tremendous. So let's start with defining polypharmacy. In a broad sense, it's where patients are on multiple medications, but I'm specifically focused on problematic polypharmacy. So sometimes patients need to be on 5 or more medicines. They may have diabetes, they may have hypertension, they may have had strokes or seizures in the past. And so when we're looking at the focus, it's on the problematic polypharmacy. And so I'll also give us some additional definitions as I go into this. And one important definition that we'll look at is for patients that are frail. And so when we look at polypharmacy, about 60% of patients that are frail meet the criteria for polypharmacy when I'm defining that as 5 or more medicines with regular use. And regular use usually means daily use. And about 20% of those frail patients have 10 or more medicines, and that's hyperpolypharmacy. So here in Florida, we have had patients weaned down on more than 10 medicines. And many of those patients, again, this is anecdotal, these are individual patients, but they report a greater quality of life. And we'll go through some of those medicines that they have weaned down on. And so to formally give you a definition of frailty, these are patients that deal with weakness, they deal with weight loss, many of them have exhaustion, and that exhaustion may not be closely connected to when they take their medicine, so it's more of a chronic accumulation of the medicine, so it may not be specifically associated with what they're taking. Many of the patients may be taking muscle relaxants, also called antispasmodics, and those can cause fatigue over time. Many of the patients may be taking high doses of supplements, and they're not sure why they're taking a supplement or when it was started. So the rationale and the method of helping patients overcome this is called de-prescribing. And so we're just doing the due diligence to go through the patient's medicine, making sure when they do their intake that list is accurate. There may be some medicines that just get carried over, maybe they were in the hospital, but they get carried over from before they were in the hospital and they're not actually taking. And there may be some medicines that's missing that they were discharged on, that's not on their updated medication list. And so this is where our assistants can really help us. Our medical assistants, our nurses can really help us by, being strong team members and getting an accurate intake. And patients should be, especially on that first visit, encourage them to bring in their medicine. Because we don't want to, start weaning down on medicine without clear communication. And part of that communication is often missing from the prescribing physician. And maybe there was an education when they first started it, but now you've been on that medicine for 2 years. Have we updated you on the side effects? Have we updated you on the risk? Most likely the patients haven't been updated and the caregivers haven't been updated. And so we obviously have a growing acceptance of cannabis. We have over 900,000 patients here in Florida, and Georgia has a growing program that I'll get into in more detail. And we also have an increasing number of healthcare providers that understand the endocannabinoid system. I remember when cannabis first became legal here for medical use, I gave a presentation at Mayo Clinic in Jacksonville, and I asked, it was a group of cardiologists, and I asked them to raise your hand if you've ever heard of CBD. It was only about 5% of people. It was over 100 people in there. Only about 5% raised their hand and knew what CBD was at that time. But because everyone here is doing an excellent job of educating yourself, educating your colleagues, educating your patients of the endocannabinoid system, there is much wider acceptance of cannabis, and we can see that's evidenced by the number of qualified patients we have. So just thinking about some of the discovery, and keep in mind, and I purposefully kept this to things that were discovered before 2000, just to remind you that a lot of this data has been out for decades, and it needs to be in our formalized textbooks in the medical, the nursing, pharmacy, medical assisting. It needs to be in our textbooks, and there's no excuse to not have it in there. This is information that's been around for more than 25 years now of THC and how it works, the cannabinoid receptors, our own cannabis, so the AEA, so the anandamide, how that works and how it interacts with receptors for pain has been known for more than 25 years. So let's start with the potential for opioid reduction. And there is evidence that the combination of THC and opioids can be beneficial. Ultimately we hope we can wean patients down on opioids, but if you can't, there still is some benefit that patients can wean down significantly. There's one particular study that showed that patients can wean down to about a fourth of what they were taking. So in other words, cannabis combined with opioids can be 4 times more effective. So if a patient was on 40 milligrams of morphine when they came, they could potentially be on as low as 10 milligrams. If they were on 80 milligrams when they came to you, they could potentially be on 20 milligrams after getting a good cannabis regimen. And so the great thing about this data, even though it's observational, is that it is reproducible. And so these are studies that were done in Michigan, here in Florida, a study in Canada, and another study that combined various data and looked at how much morphine milliequivalents can we wean patients down. And one study showed about 80% morphine milliequivalents for opioid use. And of course, we're dealing with chronic pain, so the patients may be on other medicines that may be helping, but I would recommend to start with opioids. Opioids have a black box warning for respiratory depression, abuse, dependence, and when they're combined with other medicines like benzodiazepines, you could have severe respiratory depression and coma. And so this is what we want to prioritize is the opioids, to reduce those first if we can. And when we look at these studies, we want to keep in mind observational studies. Yes, they can have some selection bias because the patients are very motivated to wean down. They may be coming to you because they have a perception that cannabis is safer because it's natural. And there can also be some recall bias, so maybe the patient overestimated what they were taking before. But we just want to keep that in mind, that there can be some biases with any type of study. And in addition to looking at opioids, we want to consider weaning down on benzodiazepines. Again, another medicine with a black box warning. And what is the long-term risk of benzodiazepines? There is, along with opioids, associations with Alzheimer's. And so cognitive decline with long-term use. And most of the observations that we have in healthcare are dose dependent. So the higher the dose of benzodiazepines, the more risk that there is. So you would want to prioritize a patient that's on 2 milligrams 2 or 3 times a day to wean down. And it's important to wean down the patients that are on a half a milligram or 1 milligram a couple of times a week, but you want to prioritize those patients that are on the higher dose. And I'll get into the strategies a little bit later. So in this particular study, the patients were able to wean down on benzodiazepines. About 30% were completely off at 2 months, and nearly half were off benzodiazepines at 6 months. And so this is, of course, an area where we want to be very patient with the process, because weaning down too fast can, of course, cause a withdrawal seizure. And one good thing about cannabis is some formulations can also help with seizures. So if the patient is also on a regimen that includes CBD, it could potentially, now there's not randomized controlled trials looking at weaning down on benzos. There is for hereditary seizure disorders, but theoretically it would have a protective effect. But in either case, I would recommend to just be cautious as you're weaning patients down, and anticipate, if they're on daily doses, anticipate weaning them down over a month or 2, or potentially 3 months, and just be more patient with that process compared to opioids. So what are the safety concerns? I mentioned one, which is withdrawal seizures. The other thing I want you to keep in mind is that CBD has rigorous controlled trials. And so out of the medicines that are FDA approved related to cannabis, it has the most rigorous studies that's available. And so as you're advocating, let's say for rescheduling, for example, this is a medicine that does not have a black box warning. Marinol has been FDA approved for decades, so that's synthetic THC. There's no black box warning on Marinol. Okay, so we're switching from dangerous medicines that have potentially severe long-term complications and potentially death to medicines that, Even the FDA has not put any specific deadly warning on those medicines. So we can use this as fuel. We can really use this and reference this through their own history of actions of what's taken place. And, you know, I do want to just remind everyone that a lot of these benzodiazepines, they're what we consider dirty drugs. And by dirty drug, I mean that there's a lot of active metabolites. And so there is published data on clobazam and the interaction of CBD, which can inhibit cytochrome 2C19. So it can slow the metabolism. And so when we think about CBD, how many think about CBD as something that can cause sedation? Yeah. I don't think of it as something that can directly cause sedation, but it can here indirectly cause sedation. So let's say a patient is therapeutic on clobazam. You can also consider clobazam in the same category of diazepam, right? Because they're both medicines with long half-lives. They both have metabolites with long half-lives. So if you're starting CBD and the patient is, let's say, therapeutic on that, and that's not being weaned down, now they can become super therapeutic on clobazam or super therapeutic on diazepam. So those patients you want to follow more closely. I would encourage you not to just follow up in 7 months. There may be a push for the patient to request to be, followed up once a year or every 6 months. But don't let that stop you from recommending that they follow up sooner. You can't force them to follow up sooner. It's out of pocket. They do have to pay. In some cases, they can get reimbursed by the workers' comp. I have seen that happen before. I have seen some injury patients get reimbursed, but they do initially have to pay out of pocket. But that shouldn't stop you from doing the due diligence to recommend that they follow up sooner because of these potential complications that we want to be aware of. All right, so antidepressants, there's not as much data about this, but again, black box warning for suicidal behavior and thoughts. But we do want to encourage patients that's on antidepressants, not just for those reasons, but also the sexual side effects, which can worsen depression. We also want to look at, and there's some good evidence on quality of life. Dr. Trout did a good job of mentioning stress, depression, chronic pain. So if we're optimizing these, we'd imagine quality of life is going to improve. And there's a lot of great quality. And even studies here in Florida have shown that 90% of patients felt that cannabis was very effective or extremely effective in improving quality of life in chronic pain patients. So let's look at the Florida structure for a moment. I'm staying on time. I got you. I'm staying on time. We have the qualified conditions, and one great thing that gives us flexibility is we have chronic non-malignant pain listed. Then we also have terminal conditions, and we also have same kind or class that opens it up for many more conditions. So if you have Dr. Rosado talked about traumatic brain injury yesterday. So you can qualify a patient because traumatic brain injury is inflammation of the central nervous system, very similar to multiple sclerosis. So we can use this information to help us qualify patients for many other conditions. And I color coordinated these. You got to coordinate here. With mental health is in pink here, so anxiety, depression, insomnia. You have sympathetic dysfunction. You have limbic system, so the emotional centers are dysfunctional in these other categories. For neurologic conditions, and the reason I included arthritis as neurologic, because you're carrying a pain signal. You're eliciting a pain response with normal activity. So that's not only a dysfunction of the orthopedic system, that's a dysfunction of the nervous system. With spasticity, that was one of the initial qualified conditions when we had low THC. But you can continue to classify someone with contractures, even if they don't specifically have pain. You want to help with a range of motion. And then looking at things like hepatitis C, which there is good evidence that there's better outcomes and reduce inflammation in the liver in patients with hepatitis C and HIV-related hepatitis, and some degree of normalization in human studies of the liver function test. So looking at Georgia, I think Georgia has an up-and-coming program. There has been discussion of changing it from low THC oil. They have essentially the tablets, topicals, and tinctures formulations. A max of 20 fluid ounces of oil is available. And the great thing about Georgia is they have 17 qualified conditions. I think there's been discussion of adding nausea. One area I think of improvement is that a lot of the conditions have to be severe or intractable for the patient to qualify. The majority of patients there qualify based off of intractable pain and PTSD. But it would be nice to advocate for conditions that are similar or of the same kind to open it up for more patients. And why are patients coming to us? They're coming to us because there's dissatisfaction with their current regimens. There's a desire to reduce the pharmaceuticals, even though we should start these active discussions when they're on pharmaceuticals, but a lot of times the patients will come to you, they'll say, I want to wean down on this medicine, or as a caregiver, I want my loved one to wean down on this medication. And then there's the perceived, safer because it's natural, which a lot of things that patients take, even supplements, are perceived as safer just because they come from natural sources. So what are some examples of how a patient can start low and go slow? I put here on purpose just to remind us that there's more than one way to start low and go slow. The first one is really just an ultra low and slow. So for example, starting a patient on 10 milligram CBD capsules, if they're on diazepam, if they're on clobazam, that might be a way to initiate and monitor them, make sure they're not getting signs of sedation over that period of time. So you may start that in a daily regimen simultaneously while weaning down on the long-term benzodiazepines. Another regimen, I call the second one my 2 to 5-25 rule, where 2 to 5 is the dose of milligrams you start with a potent phytocannabinoid such as THC or CBN, and 25 milligram is the increments that you would dose something like CBD or CBG, which are the non-psychoactive phytocannabinoids. And we want to educate patients on their routes of administration and how fast they should expect relief, specifically on edibles, so they don't overdo edibles their first couple of times. And as a warning, we want to remind patients not to initially drive when they're starting edibles. So maybe start it on a weekend where you're not driving until you become acclimated about how the medicine affects you. The same that we would do with the muscle relaxants, which can cause sedation. The same that we would do with sleep aids. It's usually better to start it on the weekend, so the patient's not waking up in the morning, they're groggy and getting an accident because of delayed reaction time. So medication reduction, there is great observational data showing that there's an association. Again, we can't say causation because it's observational. There's other factors involved, and you may be educating your patients more than the prescribing physician on the importance of weaning down those medicines. So that education, it's a good factor that we're doing this, but we have to consider that there's other factors involved, not just starting cannabis alone, but knowing how to navigate that road of weaning down. You may have many patients that they just haven't weaned down because they don't know how to do it safely. But when you educate them, now they have a better understanding, now they're more motivated to do that. Looking at anti-epileptic drugs, there is robust evidence, very strong evidence, randomized controlled trials for epilepsy. Quality of life is something that's been reproduced in several contexts, showing that patients do have a quality of life. So overall, we want to say that the potential is suggested. We don't want to say 100% definitive because it's not randomized control, but it's highly suggestive and it's reproducible in large-scale databases in multiple countries. So, I just mentioned the downside about observational data and why we should continue to encourage randomized control data. And we also want to inform patients that there are some risks associated with cannabis. So if someone has a cardiac condition, and this was mentioned earlier, that you would want to be more cautious with starting THC products. Even consider starting at 1 or 2 milligrams if a patient will not tolerate tachycardia and paranoia. Most patients, they should also look out for dizziness, dry mouth, and things like that. So in summary, I want us to focus on problematic polypharmacy. So it's not just the fact of being on 5 or more medicines, but it's the patients that are frail, that are at highest risk of cognitive decline, dizziness, falls, drug-drug interactions. We want to look at and understand that. And I would say communicate this to the caregivers as you have other people involved that, this frailty, it may to some degree be caused by this regimen of medicines that the patient is on. And so they should also go to their primary care doctor. They should also go to their pain doctor to facilitate these discussions, to their neurologists, to look at, the importance of weaning down. It's a difficult conversation sometimes when I don't want us to feel like it's us against the other doctors that's prescribing all this medicine. But sometimes, physicians that are specialists, they don't spend the time that's needed to properly consent. But it's not a this doctor versus that doctor. It's just that we're just trying to optimize the current situation based on up-to-date research that we now have here that we can present. So I would also encourage you to consider having the patients, seek other specialists. So nutritionists are a good resource for us. Physical therapists are a good resource for us, especially for our Parkinson's patients. There's a lot of data that shows better outcomes with Parkinson's when patients can participate in aerobic exercise. Aerobic exercise is also important for patients to maintain their body's endocannabinoid system, as well as there's some dietary things they can do to increase their omega-3s to support their body's endocannabinoid system, which ultimately will improve the long-term outcomes. So let's continue to inform each other and provide testimonies on deep prescribing. I would encourage you to publish those studies, even though they're anecdotal, because you guys are the patients you guys are the physicians that's giving the recommendations for the patients that give me this positive feedback on I've weaned off of 8 medicines, I weaned off of 10 medicines. We've had a couple patients weaned off of 12 medicines. Probably the highest was 14 medicines. It was a patient that was dealing with chronic pain. So on short-term and long-term opioids, anti-inflammatories, antispasmodics, benzodiazepines, anti-epileptic drugs. Patients also had seizures and insomnia. And that's a huge success story for someone that weaned down on 14 medicines over a period of 6 to 12 months. That's very impressive. And I think that type of research and data is definitely worth, writing a report, definitely worth working with organizations like Mary, who is doing great research, working with organizations like University of Florida and the consortium that's doing great research and great education for us here in Florida. And we can be more or less a gold standard for other states to follow. And we are a retirement state. We have one of the largest populations of 65 and older. We have retirement communities where the average age is over 70. We have multiple retirement communities where the average age is over 70. So we should definitely continue to share that data. Take these surveys. There's physician-based surveys. Encourage your patients to participate in surveys. And please inform us of any updates that you have for us where we can participate and encourage the great information that you're gathering, that you're sharing. And I believe there's someone from the consortium here, if you could raise your hand. So members of the consortium back there, please engage them and get to know them as well. So you can help share that data on the deep prescribing that you all are doing an excellent job on. And I just want to encourage you and conclude by saying that these are some good polypharmacy studies that I would recommend to look at. And I looked at a lot of them. A couple of these are older studies, but this is just to show you that this is a global problem. So we have data that's extracted from the United States, but also data that's from Spain, Italy, and Canada. And this last study, it's an older study from 2013, but this looked at databases and publications ranging from over 100 patients to 64,000 patients. So these are huge databases that we can use to understand polypharmacy and its association with frailty, and just get a better understanding of how to best serve our patients. All right, thank you, and here's my contact information if anybody has any questions or concerns. Also reach out to our community educators as well. We have community educators in every part of Florida as well as in Georgia. And please engage and try to, continue to raise awareness about the great job you all are doing. Thank you. 5 minutes.
That's yours, buddy. Got my 5 minutes back. Thank you so much. We're quite on time.